with a talk about the IN.PACT SFA trial. These are my disclosures. So there have now been numerous randomized trials of drug-coated balloons which have shown to improve outcomes with DCB compared to standard balloon angioplasty, including trials involving the three commercially available devices in the U.S., the Lutonix, Stellarex, and the IN.PACT Admiral balloon. Despite this plethora of data, though, there's limited longer-term results from these trials, and so it's my pleasure to be able to present the final 5-year outcomes from the IN.PACT SFA trial. I was co-PI for this trial with Peter Schneider and Gunnar Tepe. This was a two-phase trial. First phase took place in Europe, and phase 2 took place in the United States. Ultimately, 331 patients were randomized between DCB and balloon angioplasty. There was good scientific rigor with independent and blinded core labs and independent safety monitoring board and CEC. Patients were followed out to 5 years as part of this trial. We previously published the 1, 2, and 3-year results from this study. The 4 and 5-year results have been presented in public, and actually the 5-year manuscript has been accepted for publication in Circulation Cardiovascular Interventions. The primary endpoint of the trial was primary patency at 12 months, defined by freedom from clinically driven target lesion revascularization and duplex ultrasound-derived restenosis. We did duplex annually out to 3 years in this trial, and then from 3 to 5 years, the follow-up was clinical, focusing on clinically driven target lesion revascularization, which was defined as any intervention due to symptoms or a drop in the ABI of greater than 20% or greater than 0.15 when compared to the post-procedure baseline ABI. In terms of the baseline patient characteristics, fairly standard for a trial of this nature. The lesions were of medium complexity, lesion lengths around 9 centimeters, total occlusions in 20 to 25% of cases. We tried very hard not to have a lot of stenting in this trial to avoid muddying the water, and we were largely successful. There was a 7.3% provisional stent rate in the DCB arm of the trial. If we look at the study results over the years, we see a dramatic benefit with regards to primary patency at 1, 2, and 3 years, with a delta of benefit at 3 years of 24.4%. Not all of these patients with restenosis needed intervention, so the delta of benefit's a little bit smaller when it comes to freedom from clinically driven target lesion revascularization, but we still see significant and durable benefit out to 5 years with regards to the need for additional interventions, although clearly there's some narrowing of that benefit over time. And if we look at the Kaplan-Meier curves for freedom from CDTLR through 5 years, we see 74.5% freedom from additional procedures for patients who are treated with drug-coated balloons versus 65.3% for those treated with standard balloon angioplasty. One could argue the importance of this endpoint, but for those people that did need an additional procedure, the time to that additional procedure was much more prolonged if they were treated with a drug-coated balloon up front compared to standard balloon angioplasty. Overall primary safety composite was seen in 70.7% of patients treated with a drug-coated balloon compared to 59.6% for those treated with standard balloon angioplasty. There was numerical differences with regards to all-cause death, and there'll be a lot of talk about safety of paclitaxel over the course of today, but those differences in death rates at 5 years were not statistically significant. There was only one major amputation in the trial, and there was a very low rate of vessel thrombosis in both arms of the trial. In terms of the deaths that did occur, there was really no clustering in terms of cause of death. These people died basically of the typical things that elderly patients die from. And the CEC adjudicated all of these deaths as to being non-device or procedure related. There's been some talk about the higher doses of paclitaxel potentially being a cause of morbidity and mortality in some of these trials. And we found that there was no relationship between the paclitaxel dose and mortality rate. The dose was similar for patients who died compared to those that survived, compared to those that were lost to follow-up. Now, in terms of the overall IN.PACT DCB clinical program, there was one other randomized trial, the IN.PACT Japan randomized clinical trial. It was a smaller trial, 100 patients were randomized in this trial. We have 3-year outcomes from the IN.PACT Japan trial showing significant benefit with DCB with regards to primary patency with a delta of benefit of 22%, almost exactly the same as we saw in the IN.PACT SFA US European trial. We saw no differences with regards to all-cause death in the Japan trial, again with no major amputations and a very low vessel thrombosis rate. Again, if we compare IN.PACT SFA with IN.PACT Japan, we see remarkably similar results, similar lesion characteristics, very similar primary patency at 3 years, very similar freedom from, or very similar CD-TLR rates, and very similar safety profile. So in summary, IN.PACT SFA was the first independently adjudicated, blinded, multi-center randomized trial to demonstrate superior effectiveness of a drug-coated balloon with durable outcomes through 5 years. As mentioned, there were no device, procedure, or paclitaxel-related deaths through the 5-year endpoint in this trial, with very low thrombosis and major amputation rates. Thank you very much for your attention.